The physical exam gives us these incredibly strong clues, but modern diagnosis really relies on imaging and electrical signals to confirm severity and, importantly, plan an intervention. Let's start with the electrocardiogram, the ECG. What can the P wave tell us?
In a patient with MS who is still in sinus rhythm, the P wave gives us some really good initial clues about the LA chamber. A classic finding is a broad, notched P wave, which suggests left atrial enlargement. The pressure is causing the LA wall to get bigger and conduct electricity differently.
And what happens electrically when that pressure has backed all the way through the lungs to the right atrium?
If severe pulmonary hypertension, or rarely tricuspid stenosis, is also present and the right atrium starts to enlarge, the P wave changes again. It can become tall and peaked in lead too, which suggests that added right atrial strain. And while the main part of the ECG, the QRS complex, is usually normal, severe PH often leads to right axis deviation and clear evidence of right ventricular hypertrophy. The electricity confirms the pressure backlog.
Okay, let's talk about echocardiography, which is really the gold standard here. The TTE, the transthoracic echo, is the first line.
TTE is absolutely critical. It gives us objective numbers to quantify the problem. We can measure the mitral inflow velocity, how fast the blood is moving, looking at the ENA waves. And crucially, it allows us to estimate the pressure gradients and the mitral valve area, the MVA, often using a method called pressure halftime.
Can you give us an example of how those numbers translate into a concrete diagnosis for us?
Certainly. In a severe case, the TTE calculations might show an MVA that's reduced to, say, zero point 0.7 square centimeters, which is way below the severe threshold of 1.5. And it might show a mean pressure gradient of 38 millimeters of mercury. Those numbers take the diagnosis from abstract clinical findings to concrete, quantifiable severity that demands action.
And beyond flow and pressure, the TTE also tells the cardiologist about the valve's actual physical structure, which is vital for choosing the right treatment.
Yes, TTE is essential for assessing the leaflet calcification, the restriction, the distortion of the subvalvular apparatus.
Yeah.
All the things we talked about earlier. These structural features are vital for judging if a patient is a good candidate for specific intervention, like a percutaneous mitral balloon commissurotomy or PMBC, which we'll get to. Plus, it gives us assessments of both LV and RV function and a crucial non-invasive estimate of the pulmonary artery systolic pressure.
What about the TE, transesophageal echocardiography? It's more invasive, so when is that specifically needed?
T gives you these superior high-resolution images because the probe is right there in the esophagus next to the heart with no ribs or lungs in the way. Its single most important specific role is to definitively rule out the presence of a left atrial thrombus before performing a PMBC.
And why is ruling out a clot so absolutely non-negotiable before that procedure?
Because if there's a clot in the LA and you advance a catheter across the septum and inflate a balloon, you could easily dislodge that clot. That would cause an immediate and potentially fatal stroke. TE provides the necessary surgical clearance, if you will.
Finally, the chest X-ray. It's often an early step, and it can offer some classic visual clues of chronic MS. What should we be looking for?
The early changes can be subtle. You might see a straightening of the upper left border of the heart silhouette. More advanced signs include a prominence of the main pulmonary arteries and dilation of the upper lobe pulmonary veins, showing that blood flow is backing up. And critically, the enlarged left atrium can actually push backward on the esophagus.
But the most specific sign of chronic high pressure, the one that really confirms lung congestion, are the curly B lines.
Curly B lines are a classic radiological sign of decompensation. They're these fine, dense, opaque, horizontal lines that you see best near the outer edges of the lower and mid-lung fields. They are the physical manifestation of that interstitial edema we discussed. They result from the distension of the intralobular septae and lymphatics with fluid.
So if the LA pressure is constantly pushing fluid out into the lung tissue, the curly B lines are literally the visible water damage of that chronic congestion on the X-ray.
Precisely. Our sources indicate they're usually a sign that the resting mean left atrial pressure has exceeded about 20 millimeters of mercury. It's a powerful visual confirmation of that high-pressure environment inside the lung tissue itself.
Okay, once mitral stenosis is confirmed and quantified, we move into treatment, starting with prevention and medical management.
Prevention is the bedrock, especially in high-risk populations. For patients who've had rheumatic fever, penicillin prophylaxis for secondary prevention is absolutely vital. It stops the recurrent infections that trigger more inflammation and worsen the valve damage over time.
For the patient who is already symptomatic, what's the immediate medical goal for symptom relief?
The immediate goal is twofold: reduce congestion and manage the heart rate. So, restricting sodium intake and using small doses of oral diuretics can usually offer some improvement in the congestion symptoms by reducing the overall fluid volume.
And for rate control, especially in patients with atrial fibrillation, what's the approach? We need to slow that heart down to give it more filling time.
Exactly. We need to slow the ventricular rate to extend diastole, maximizing the time for flow across that stenotic valve. Beta blockers are excellent for this. So are the non-dihydropyridine calcium channel blockers like verapamil or diltiazem. Digitalis is also used, though it's less effective. Rate control is a critical first line of defense against those acute pulmonary edema episodes.
Let's talk about anticoagulation. This is vital because of that high risk of clots we discussed. Who specifically needs lifelong therapy with something like warfarin?
Anticoagulation is non-negotiable for three groups of MS patients: those with AFib, whether it's persistent or paroxysmal, those with a history of thromboembolism like a prior stroke, or those who have a demonstrable clot in their LA on imaging, even if they're in sinus rhythm. We usually target an INR of 2 to 3.
This is a really crucial detail, especially with all the modern direct oral anticoagulants like rivaroxaban that are so common now. Do they apply here?
This is paramount, and it's a major deviation from standard practice. We have to highlight the specific evidence here. There's a randomized trial looking specifically at patients with rheumatic MS and AFib, and it showed a significantly higher incidence of death and thromboembolic events in patients treated with rivaroxaban compared to those treated with a vitamin K antagonist, like warfarin.
That is a staggering finding. So, unlike most other forms of AFib, rheumatic MS demands the use of the older anticoagulants.
Absolutely. So the sources are crystal clear on this. A vitamin K antagonist remains the recommended therapy. The novel anticoagulants are simply not proven to be safe or effective in this specific high-risk population where the valve itself is often the source of turbulence and clot formation.
Okay, moving beyond medical management. When is an interventional procedure, a repair or replacement indicated?
Intervention becomes necessary when medical therapy just can't control the symptoms anymore. So commissurotomy, the procedure to open the valve, is indicated in symptomatic patients who have isolated severe MS, meaning an MVA less than 1.5 square centimeters.
And option one, the preferred approach for the right patient, is the less invasive procedure. Percutaneous mitral balloon commissurotomy, or PMBC. How does that work?
PMBC is a catheter-based procedure, no big incision. A catheter is advanced from the groin vein up to the heart. Then, through a transeptal puncture piercing the wall between the atria, it enters the left atrium. The catheter is maneuvered across the stenotic valve, and a special balloon is inflated, stepwise, in the orifice. The goal is to mechanically split those fused commissures.
It sounds like a great solution, but it's not for everyone. What is the ideal candidate profile? This seems like an aha moment for anyone learning this.
The ideal candidate is highly specific. We're looking for patients whose main problem is that commissural fusion, but whose leaflets are still relatively pliable, still mobile. They must have little to no calcium on the commissures, and critically, no significant scarring or thickening of the subvalvular structures.
And no clot.
And absolutely no LA thrombus, hence the TE, and any associated mitral regurgitation should be mild, say 2 out of 4 or less.
And when PMBC is done on that ideal patient, the outcomes are impressive.
The outcomes are comparable to open surgical repair, but with much less morbidity and lower mortality. For younger patients under 45 with pliable valves, PMBC is the procedure of choice globally. It offers excellent event-free survival rates, as high as 80 to 90% over 3 to 7 years.
And to help guide that decision, the echo gives us a predictive score.
Yes, the echo score, or Wilkins score. This is vital. It assigns points based on 4 structural factors: leaflet thickening, calcification, mobility, and subvalvular thickening. A lower overall score, usually less than 8, predicts a much higher chance of a successful PMBC. A high score suggests the valve is just too stiff, too calcified, or too distorted.
Now, if PMBC is unsuccessful or impossible because of that unfavorable anatomy, then the patient needs option 2, surgical or open commissurotomy.
All right, there's open heart surgery using cardiopulmonary bypass. The advantage is direct visualization and a broader scope. The surgeon can do more than just open the commissures. They can loosen fused chordae, physically remove big deposits of calcium, and take out any atrial thrombi. The goal is still repair, if possible.
And finally, mitral valve replacement, MVR, which is necessary when repair just isn't feasible.
MVR is for patients with significant associated mitral regurgitation or those whose valves are just too severely distorted, calcified, or scarred to be repaired. The criteria are strict. It should only be done if the patient has severe MS, an MVA of 1.5 or less, and is highly symptomatic, so NYHA class 3 or 4, despite optimal medical therapy.
And modern technique makes sure the replacement optimizes the function of what's left behind.
That's right. MVR is now routinely performed with preservation of the chordal attachments to the papillary muscles. This is crucial. Preserving those attachments helps maintain the geometry and functional recovery of the left ventricle after surgery, which significantly improves the long-term prognosis. And that leads to a final provocative thought for you to consider. Given this global disparity, and considering how effective percutaneous mitral balloon commissurotomy, that relatively low-cost, less invasive balloon procedure, has proven to be for young patients with pliable valves,
Right.
what does the future hold for expanding access to interventional techniques like PMBC in the low-income regions of the world? If we can treat the root cause of the most devastating symptoms cheaply and effectively without open-heart surgery, what are the next steps in medical infrastructure to ensure we have global equity in mitigating mitral stenosis?
A fascinating medical, economic, and really ethical challenge for the decades ahead. Thank you for diving deep with us.